Good afternoon and welcome to this webinar on valid and reliable psychological assessments in telehealth, proudly co-hosted by Coviu and Pearson Clinical. So my name is Peter Simpson-Young. Although I originally studied psychology, I'm part of the Coviu team and your host for today's webinar. So I'm now joined by two of Australia's leading experts in telehealth psychology, and will be followed by a live Q&A. And our experts include the Director of Swinburne University of Technology's National E-Therapy Centre, Associate Professor Neil Thomas, and Dr. Melissa Stevens, a clinical neuropsychologist at Pearson Global. So over the next hour, we'll be diving into some of the latest research in telehealth psychology and psychological assessments and the best practices for delivering telehealth assessments and increasing sort of test validity and maintaining examining attention. And we'll be showcasing at the end some of the latest telehealth assessment technologies. Now, let me briefly go through some of the housekeeping items for today's webinar. So as some of you can already see, feel free to pop any questions or comments in the chat on the right-hand side of the screen. And love that some people are introducing themselves. Feel free to continue doing that. And the presenters or myself will try and get to those at the end of the session. Now, a link to the recording and slides will be emailed through in the next couple of days. So just keep an eye out in your inbox or other email folders. And of course, if you need any assistance, feel free to pop them in the chat or reach out to us via live chat at coviu.com. But before we begin the presentation, the other presenters and I would love to just get a quick sense of who else is in the room. And I'm just going to kick off with a quick poll to understand who is in the audience. Bear with me a second. So as you can see on the right, there's a quick poll just asking about your occupation, you're a psychologist with general registration, a clinical psychologist, neuropsychologist, psychiatrist, counselor or psychotherapist, or other. And I'll just wait for a few moments for people to put in their answers. So we're at 56% psychologist with general registration, 20% clinical psychologist, and 15% other. Fantastic. I'll end that poll and just publish the results in case anyone's interested. And I'd also love to know who the other are. That would be fantastic. So great. So I'd now like to hand over to Associate Professor Neil Thomas, and I'll speak to you later. Thanks.
Hi, so thanks for inviting me to be part of this forum. I'm going to speak a little bit about some of the work that we've done thinking about the use of video conferencing in psychological practice broadly, before the drill down into thinking about assessment specifically. And so what I'll do is think a bit about some of the evidence that there is. We've recently done a review of that evidence, the empirical literature, and then also think about some of the practice adaptations that we use ourselves. So in terms of understanding the sort of where I'm coming from, I mean, we run we run a number of services which utilize video conferencing. We've run an online mental health service that's funded by the Australian government called Mental Health Online, which offers self-guided mental health resources, and we offer some support to some of our users. We've got over 100,000 users. Some of those we offer support to using video conferencing as a modality. We also, before the pandemic, we run a specialist clinic for people with severe mental health problems struggling with persisting voices, and that to enable that to be offered to people in non-metropolitan areas and nationally, we've been running that via telehealth in part and at the moment fully with the pandemic going on. And also with the pandemic, there's some other initiatives that we've been running at Swinburne, such as the psychology clinic, which went fully into the telehealth mode during the pandemic, and also an InReach service for older adults in residential aged care, providing psychology services to them, which again with the pandemic turned into actually quite an important telehealth-based service. So what I'll do is I'll start by talking about this, where the literature's standing at the moment in terms of understanding the role of video conferencing. This is based on a review which was recently just been published in Psychology and Psychotherapy Journal. This is an open access paper, so I invite you to check that out, which you should be able to find for more details. Our interest here was looking primarily at an adult population and primarily looking at video conferencing to deliver psychological therapies to people with mental health problems, and looking at really what the literature was saying about that at this point in time. We found that there was over 50 studies which have been conducted, at least 20 of which were randomized trials. And in thinking about this data, we wanted to try and bring together something that would be useful for practitioners in understanding what we know about this modality of delivery at the moment. So what's the feasibility for different populations? What client experiences, what therapist experiences, and in contrast, where there's been a randomized trial comparing with in-person delivery, how does video conferencing-based delivery stack up in terms of acceptability, therapeutic alliance, and outcomes? So, I mean, this is just an overview of the studies which we identified. A lot of research has been done in PTSD, partly because of funding from the US Veterans Administration, also in depression and anxiety disorders, less in other populations, but we have, generally a sense of a fairly good spread across populations, in people in mental health population. In terms of interventions, primarily CBT-based interventions have been examined at this point. So a bit our synthesis of what client and practitioner experiences were. Many people would express a preference for in-person, but in terms of actual satisfaction with when people received, that we found that overall people were rating video conferencing as being acceptable. We also found that people were sometimes reporting some period of adjustment, so sometimes feeling a bit uncomfortable at first, needing a bit of time to adapt, but that was something which reduced over time when people got used to it. Access was a dominant theme in terms of people thinking about the advantages of what can be done with video conferencing. So in terms of this, I guess obviously we've got geographical, but also in terms of people being able to afford to get to sessions, the time, and also barriers such as anxiety about making appointments, the stigma of going to a public location to access psychology. So there's a number of access barriers that potentially this could overcome. In terms of issues, privacy was an issue for video conferencing in a different way, that people can be concerned about other people in their own home environment. That often came up as an issue. But probably one of the most common things that we heard from the literature is therapists having concerns about finding it more difficult when not in the room physically with somebody about being able to read report. And we'll come back to that with thinking about some of the specific findings. So in terms of the quantitative results of this review, what we found was a pretty consistent picture in which we were really not finding any substantial on average differences between video conferencing and in-person therapy. We also looked at measures of the therapeutic alliance. So this is a measure of rapport, or most commonly used the working alliance inventory. Again, very, very few differences on average in terms of the alliance. With very, very marginal inferiority in one trial, the Moreland trial, but then another one finding that video is actually superior. And in terms of outcome, again, very similar picture. So if we think about many of these studies, we're using a non-inferiority design, so they were powered to look at a predetermined margin of whether or not one intervention was superior to the other in order to be able to test out whether there was a difference. And these were finding no significant differences. And able to conclude non-inferiority. So in terms of making sense of this, I think it's actually been very helpful to review this literature and find that on average the experience of video conferencing therapy is satisfactory, is acceptable to people, and produces similar outcomes. There's some caveats to all of this research, limitations to it. I encourage you to look at the paper to follow up with some of our discussion of that. But certainly something that was coming out was the sense that as practitioners, and myself included, when we're doing therapy over video conferencing, we can feel that it's not quite creating the same thing as it would be if we were in the room. But some of this is to do with our difficulties in reading rapport and adapting our own practice to working with people. When we look at the client experience in terms of acceptability, in terms of their perceptions of rapport, and in terms of outcome, actually it looks like people have a very good experience of this. We should bear in mind, though, that there's going to be differences. So there are certainly some people that struggle with using video conferencing, but because things are averaging out, it's also suggesting that there's some people that would struggle with in-person, and there's actually advantages of video conferencing. So all in all, we have to pay some attention to individual differences, but on average, it looks like it's comparable at this point in the literature. So I'll go on to think about what can we do to adapt our practice. Of course, in these trials, people were using some adaptations in order to provide as good a possible service. So what were some of these things that people were doing? Early in the pandemic, we produced this document which provides a practical guide. Again, it's open access. You can access it by clicking on by navigating to videomentalhealth.org, which will go to the mental health online website where you can download it. I'll go over a very brief overview of some of these things. Basically, we were just splitting up the adaptations into 4 areas. So one, preparing yourself as a practitioner, so thinking about the procedures and so on and so forth that you need to set up. Preparing the workspace where you're in, where you're seeing people, thinking about your computer setup and your physical environment. Preparing the client, and then having some in-session adaptations as well. I'll go through these. What can we do to prepare ourselves as a practitioner? Well, this is just to sort of illustrate the challenge that the tip of the iceberg is just holding the session. There's a huge amount of prep work that goes into that in terms of thinking, well, how do I go about making choices and setting up systems and procedures? I won't go into detail about this. The APS has got good resources on their website at psychology.org.au that you can follow up for advice on those things. But it's important for us to just spend some time setting those things up. Likewise, we need to think about our workspace as well. What do we do with the setup there? So just to quickly go through, of course, what we may want to try and do is replicate an in-person consultation as much as we can. Have a think about what people can see in the background, whether there's going to be any children barging in. We want to think a little bit about the lighting and noise levels in one environment. We might be using, I'm not using headphones today, but that might be an option. Think about lighting and so on and so forth. We want to think about the framing of our face, so we're not like kind of too close to the camera in a way which can be a bit oppressive for people to be looking at, not too far away. And thinking, what can we do to support eye contact? Of course, with our setup, we want to be making eye contact with the camera rather than with the image of the person on screen, which can be a bit counterintuitive. So to support that, there are some technological modifications that are available, such as sort of device mounts that can come in front of the screen, or there's an example here on the image of using the Apple Sidecar to adapt a tablet computer as a second screen with someone's image on. Okay. So third bit is thinking, what can we do to prepare the client for the consultation themselves? So in terms of this, what we would usually do is like make contact with the person on the phone beforehand, just to be thinking through about what their needs might be in relation to the appointment. So obviously we want to think about what equipment they've got, what's available to them. We should, of course, be careful not to make assumptions. We see people with severe mental health problems who often don't have access to computers or have the bandwidth to be able to do things. So there may be some problem solving involved there, although a lot of people are actually very, very connected. And thinking about what sort of technology the person's going to be most comfortable with using. We would always have a backup mode of communication, which usually would be telephone, but also can be email, to make sure that if something breaks down, we can still reach somebody, particularly in a risk scenario. And we would also always give people some written information in advance. So we've got like a kind of 2 sides of A4, which has got lots of details on about walking through how to use the software, the thinking about any requirements that they've got, how the person might be mindful of the space that they're going to be in seeing somebody, what they can do, make sure they've got private space, and thinking about any sort of disclaimers about privacy, security, and so on and so forth. And another important area is just to be mindful of risk management. And this is all very manageable in terms of just being proactive and making sure we have things like the location and address details of the person and alternative contacts that we can utilise if there's any dropping out. And then I guess the fourth area is, well, what can we do to adapt our own communication skills in session? So I guess what we've got here is a need to emphasize some of our active listening skills that we otherwise would be reliant on happening a bit more intuitively when we're in the room with people. So that might involve more active, sort of more frequent expressions of empathy and paraphrasing and all those kind of reflective listening skills, expressing things verbally that may not come across non-verbally, and checking in with the client about how the session's going. I would usually overtly be saying towards the beginning of an appointment, look, I may not pick up on all the details that I might do if we were in the room together about how things are going. So so please let me know if you're if there's anything that comes up that you feel uncomfortable talking about, and so on, just so that I know, because I want this session to work for you. And then I would check in periodically with people about how the session's going. Okay, so that's a very whirlwind tour of some of the things that may be useful for engaging with people using video conferencing as a technology. I'd encourage you to check out the 2 resources that we've got there. So videomentalhealth.org has got the summary of those practice developments, and the journal articles in Psychology and Psychotherapy Journal are open access. Thank you.
Thanks, Neil. So I'm going to take over for the next segment of this particular webinar. But before I do, I'm just going to see if I can get another poll up and running. Pete, if you're there, I think you might just have to click out of it for me, the previous one. So I am interested this time in assessments. So Neil's obviously covered quite a lot of the background in terms of how we set up our sessions for telehealth or telepractice, how we deliver therapy, but I'm really interested to see how you're delivering the psychological assessments, particularly this year. So do you complete them in person? Are you completing them only in telehealth? Let's have a look. Hopefully this is up now. Are you usually completing them in person, but occasionally via telehealth? Are you completing assessments usually via telehealth, but occasionally in person? and anything else. So either in some other format. Hopefully one of those first four will capture most of them. I can see lots of people responding now. Thank you for engaging in that particular poll. Wow, some really wild shifts of numbers in front of me. I will just give it another little while. So the focus of my segment is obviously going to be around assessments, and in particular, for those of you who already use Coviu, our Wechsler assessments. And so I will talk a little bit about how to deliver those in the most effective and reliable way, and touch on some research that we've done, particularly in relation to the WISC that many of you have probably not seen before. And then talk about some research that's actually happening at the moment with some of our other partners using Coviu and some other telehealth platforms as well. So, okay, let's have a quick look and see whether or not we've got some good data here. So we have about 38% in person only. We've got 11% of attendees are using assessment via telehealth only. So that's quite a big group of individuals. We've got around just over a third of people using it in person, but occasionally via telehealth, and about 9% using it via telehealth, but occasionally in person. Fantastic. Okay, so let me go to my slides. And hopefully this will show for everyone. Fantastic. Here we go. So basically, we've had a few assessments come to the Coviu platform now. So some Pearson assessments, mostly our Wechsler products and our Self family. So you can see on the screen here, we can actually administer our Wechsler tools via Coviu using, in the example on the screen, the WACE add-on. But as I said, I just wanted to touch briefly on some of the probably more frequently asked questions that we get asked around the Wechlers in particular, because of course they do include aspects of the assessment that require the participants, so that the individuals that we're assessing, to manipulate. So I do just want to draw your attention though to a web page on our website. So if you go to pearsonclinical.com.au/telehealth, and if you scroll down around about halfway down the page, you'll see a section titled Important Telehealth Guidelines by Product. And in particular, for today's presentation, I thought that some of you might be interested to read about the WACE-4 and also the WISC-5 Australian and New Zealand version. So I'm going to touch on, as I said, those questions that we're asked fairly frequently certainly in my day-to-day life, working with individuals who are administering these assessments via telepractice. So you'll notice that if you click on either one of those links, it will take you to another page where there is quite a lot of detailed information around using these assessments in telehealth. So Neil has covered a lot of the background information around how you set up the environment, how, some of the considerations to make from both our perspective as examiners, but also from the perspective of the examinee. But we then really want to look at the best practice as it relates to assessments in particular. So within each of our web pages for the specific products, in this instance, the WACE-4, you'll see that we've broken it down by sections. So for those who are already using telepractice, you can probably skip some of those earlier aspects, or certainly follow through what Neil said in terms of setting up your environment to give the best engagement with the client and making sure, light and so forth that Neil was discussing, making sure audio is working sufficiently, you've got the right bandwidth, etc. But then we also want to have a look at some of the other considerations, as I said, as they specifically relate to the assessment process. So if you click on a couple of our tables within those particular sections, this is just an example of one from the WACE, and this is a subsection of a table. The table, I think, runs for about 3 pages on a PDF document, but this is just looking at the very specific subtests as they relate to the WACE, for example. So here we have an example of some of our visual tasks, namely visual puzzles, matrix reasoning, figure weights, and picture completion. And then the specific considerations for telepractice for those particular subtests. So, for example, having or needing high quality video, making sure that we're pointing to the stimuli on the screen. So making sure that you know that your mouse cursor is working, or making that emphasized in some way, and Coviu does that very well. For example, with visual puzzles, we have a recommendation here saying that we wouldn't want the examiner necessarily to use the mouse or touchpad. But again, if they do, and Coviu also does this very well, if they select it on Coviu, we can see where the individual has actually clicked on the screen, and Pete will show us a demonstration of that a little bit later. So we go through every single subtest as they relate to each of those individual tests. As I said, this is an example only for the WACE, but probably the most common question that we're asked, certainly when they're not subtests, kind of as straightforward as the ones that I've just shown you on this slide, which is, we're basically showing a static stimulus on the screen and we're asking a client mainly for a sort of multiple choice answer. So the question that we're often asked is, well, what about block design? How do I administer something like block design via telehealth? And so the research to date, although there is new research emerging as we speak, but the research to date has certainly looked at this question, and in almost all of those instances, they've either not used block design, and I'll talk about some solutions for where block design isn't administered, or they have used a professional facilitator. Now, in most of those research processes or research instances, they've used people like provisional psychologists who have been trained in the use of these assessments as part of their university degree. But the question is often asked, well, could we use someone else? If we don't have access to, let's say, some provisional psychologists in a more remote area, could we train up someone like a nurse clinician or a special education teacher, someone who doesn't necessarily know how to administer the WACE or the WISC, but who could be trained up by the psychologist to at least put the blocks on the table, have them scramble them up and present them as needed with the right number of blocks, etc. And so we would put that back onto you to make a clinical judgment around that if you believe the individual in that instance has the capacity to do that and you're comfortable providing that level of training, then that would be something that you could make a call on to say, well, I don't really have any other option, but I really need block design because I need the full scale IQ, for example. So we don't really talk about who that individual must be, but the research that's coming out at the moment, and this is the most recent one that I've heard of, is through the Murdoch Children's Research Institute here in Melbourne, and they are actually looking at trained facilitators but in a home setting. So this would be using someone like a parent or primary caregiver, a guardian, carer, etc. So we are really interested in seeing the results of that research when it's released. They are only in the preliminary stages at this point. They will be doing some sessions at the upcoming Pacific Rim conference. So I'm waiting with bated breath, basically to find out what that research is. And I'm certain that once that research is released, there's a possibility for us to run another webinar that would cover that particular information in more detail. And the main reason, I guess, is because it is sometimes very hard, as I mentioned, in those very remote instances, to get access to a professional where we would be able to provide that training. So the potential of having that option of training up a parent or that primary caregiver just gives us so much more opportunity to be able to deliver these services where they're perhaps needed the most. And so when we're unable to use a trained facilitator at this stage, obviously the option then is to omit block design. And so the question then is, well, if I can't administer block design, what can I do? Now, thankfully, within the WACE, there is the option to either substitute with a sort of non-manipulative subtest like figure weights, or you can prorate the PRI down to 2 subtests, so that would be an option. Now, it becomes a little bit trickier when, of course, we also have the response booklets of the processing speed subtests, being coding and simple search. And so when you can't administer block design or either of those 2 particular subtests, then we do lose a little bit more information in that instance. So processing speed as an index obviously wouldn't be able to be generated if we're not using those response booklets. We also have the instance where we won't be able to generate a full-scale IQ, but we can still derive information around the verbal comprehension index, the perceptual reasoning index, the the working memory index, and we can actually, using substitution, generate the GAI, which is the general ability index. So that's the index that removes the processing speed components as compared to the full scale IQ. So the question then becomes, well, if I am unable to administer those particular subtests that require manipulatives, what's the purpose of your assessment? So where it is used maybe in the purposes of diagnosis, so I'm looking to make a diagnosis around intellectual disability, and I'm constrained within the instances that I work that I need to report a full-scale IQ. At present, we would say that is unable to be generated unless you have that trained facilitator. And so you might decide to delay that assessment until you can either get the trained facilitator in, you can get the materials out in that instance. So a lot of the research to date has had the individual come into a clinic that has those materials along with that trained facilitator present. As I said, the research at the moment is looking at how do you send the information out to a house and using that primary caregiver to administer it. But for now, we would say, have them come into a local clinic. So this might be someone out in Mildura. You know, they don't want to travel all the way to Melbourne just for an assessment. Can they go to one of their local clinics where those materials and that trained facilitator are present, can still generate the full-scale IQ in that instance. If you don't need the full-scale IQ, though, it might be sufficient, if you're looking more at a strengths and weaknesses basis, to actually just use those other indices that you can generate, obviously minus the PSI. Now, the WISC, on the other hand, is a little bit different. So unlike the WACE, the WISC is a bit more rigid, I guess is the word I'd use, in relation to substitutions and prorations. So when we're unable to administer one of those primary or multiple primary subtests, there is actually very little opportunity to do substitutions. And so what we have designed in this instance is something that's called the International Non-Motor Full-Scale Score. Bit of a mouthful, and we love acronyms, so we refer to it lovingly here at Pearson as the NMFSS. And what that basically does is it says, look, we understand that in most instances, particularly when you're doing this in a home environment, while not ideal, but you can't administer block design, we've provided this non-motor full-scale score in lieu of the full-scale IQ. So you would use, rather than block design, you'd use visual puzzles. And so, and obviously without those, the coding, the response booklets for processing speed. So in that instance, what we would do is we would use the scale scores for similarities, matrix reasoning, digit span vocabulary, figure weights, and visual puzzles. You can see that just in that last paragraph down the bottom there. I realise I do read things out very quickly, but you've got the information there on the screen. And just in terms of people sort of wondering, well, how does this score relate to the full-scale IQ, you know, in terms of its reliability, for example? So what our US research team did was run through basically a correlation between this non-motor full-scale score and the full-scale IQ. So it's a bit of an ugly table, but you'll get the gist of what I'm talking about when I explain if you have a look at a couple of these columns. So the second column that you can see there, the first one with numbers, is basically our full-scale IQ. So that's that. It's titled WISC5 underscore FSIQ1 underscore SS. And versus the age group, which is the final or the furthest right column, which is age group. So age groups, as it's listed there, is just a number 1 through 11. They relate to the years, so the overall years that we test for the WISC. So 1 would equal 6 years of age, 2 is 7 years of age, etc., all the way up to 11, which is for our 16-year-olds. And the FSIQ1 column is actually the US full-scale IQ. Now, that full-scale IQ is the basis for the Australian and New Zealand full-scale IQ anyway. And the reason we can use this here locally is because our country-level adjustments actually take place at the subtest level. So what we wanted to do was have a look at the correlation between the US full-scale IQ and that non-motor full-scale score. And what we actually found was that the correlation overall is about is 0.96, which is pretty high. And depending on the various age ranges, can range from 0.94 to 0.97, which I think is pretty impressive. Now, our psychometric team used our largest and best stratified sample that we had, which is still our US sample, to calculate the composite norm values and the correlations, which I haven't put those up here. You can access them via our website and via Q Global. But basically what we found with this correlation of 0.96 is that it actually correlates more highly with the full scale IQ than our test retest does. So again, looking at the US test retest, which is obviously, again, the largest and best stratified sample that we have, is 0.92. So the fact that these two scores correlate at 0.96, as I said, I think is pretty impressive. So you can be fairly confident if you're using this. I understand a lot of jurisdictions probably don't quite understand this, this variable or this index yet, and so it's probably not one that you'd be able to use for the purposes of, say, funding, for example, or for access to certain services and so forth. But if you are using it outside of that sort of more funding or diagnostic aspect, it is something that I think you can have a lot of confidence with. We also have some references on those particular pages, again, through our telehealth webpage, that if you are after some more information around specifically just general telehealth, and Neil had some of that information on his slides as well, but we also look at telepractice versus face-to-face mode. We've broken that down. Again, you can see some tables there that go through the very specific instances around the key subtests that were administered in those instances. There's more than what I'm just showing here. I'm just showing sort of one page, but I think for this one there's about a dozen or so references. And then we're also looking at the digital versus traditional format as well. Again, I'm just showing the first four. There are many more references beyond that. So as I mentioned, we are very excited about the research that's coming out at the moment. The Murdoch Children's Research Institute, I'm particularly interested in to see how that looks with a home-based setting, as I mentioned, and very, very keen to hear that data once it's published. And there are other researchers that are looking into this as well across both Australia and New Zealand. I did see there were a couple of people from New Zealand attending today, so it'll be really interesting to see if those all align with what we so far are gathering in that preliminary data. But on that note, I will hand back to Pete.
Thank you so much for that presentation, Melissa. And I'll just start my screen share so you can see my slides. Bear with me a second. Okay, so I'm getting some feedback. Bear with me one moment. It'll be coming from, there we go. Hopefully you can all hear me fine. So just a brief introduction to Coviu. As many of you guys will know, Coviu is Australia's leading telehealth platform. We provided over 3 million consultations to 60,000 healthcare professionals in Australia. Just a reminder, obviously Coviu started as a project at CSIRO and was launched in 2018. And Coviu's key features all focus on 3 different stakeholders. So it's the clinicians, the admin staff, and the patients. So what I'm going to be talking about today is going to be, actually, before I go into that, I just want to do a quick poll just to get a bit of a sense of how people, or what types of assessments people are currently doing. So I'm just going to launch this poll. Here we go. So what type of assessments do you most commonly administer? So is that psychometric assessments like the WISC and WAST that we've just discussed, the self-report questionnaires like the DAS or the K10, so structured interviews, self-monitoring, including diaries or other? And I must apologize. I know by being here, you must necessarily be interested in assessments, and the polls here are all are not multiple choice, and so which is frustrating for you guys as well, being only able to answer with one option. So I do recognize that issue. I apologize. Okay, so I'm just going to end that poll now. Thank you so much. It looks like about half of most commonly administering psychometric assessments, as well as self-report questionnaires. That's fantastic. I'm going to be talking about both of those types of questionnaires today, and the Pearson psychometric assessments, and then a whole bunch of new questionnaires which have just been released in Coviu last week. So just quickly though, I would love to know which questionnaires and tests you most frequently administer. Again, it's quite frustrating not being able to input multiple answers, but do you most commonly do the WACE, WISC, DAS, K10? This is fascinating. So we've got 35% using the DAS, about 36% are doing the WISC and the WACE, a couple doing the personality assessment inventory. Really wish we could have multiple choice options here, but okay, fantastic. So a lot of use of the DAS. Great. Well, I'm going to be explaining how you can do the DAS through Coviu a bit later on. I'm just going to end that poll. Now, as Melissa has discussed in detail, Pearson and Coviu have developed standardized assessments which can be easily offered throughout within the video call. I'm going to demonstrate how those are designed specifically, and what makes them different to, say, just doing a in-person assessment or screen sharing the stimulus book. But first, I just want to talk about some of the research that's been published so far. As Melissa has mentioned, there's a lot of exciting research going on as we speak, but there's just two papers I thought would be worth mentioning. So a brilliant speech therapist named Dr. Rebecca Sutherland in 2016 compared the Self-4 assessment, which of course is for speech and language impairments, in 23 children at Westmead Hospital, and was comparing the scores when delivering the Self-4 via telehealth or in person. And include the 6 sort of subtests, and they were measuring reliability and feasibility. And this was one of the first studies of this at the time. Of course, there's a lot more stuff going on at the moment. And what they found was a very high correlation between telehealth and in-person scores. Similarly, there was a study of WISC-4 done by Marie Antoinette Hodge and colleagues also at Westmead Hospital, where they were administering the WISC-4 in 33 children with learning disorders, including all 6 subtests. And they were also looking at the feasibility, reliability, and acceptability of that assessment. And similarly, there was a high reliability, including each of the subtests, as you can sort of see there on the right, and high acceptability and feasibility. So the paper reports that 91% of local psychologists reported that both they and the child enjoyed using the remote assessment technology, and overall feedback from the parents and psychologists indicated strong acceptability of assessments by telehealth. Now, there's a couple of great studies coming out, and I just wanted to plug two of the projects currently ongoing, and that will be presented at the 6th Pacific Ring Conference. On the left, there's a workshop by Reen, Wendy, and Christina Habeck about delivering those. I think it's the WISC-5, as well as Susan Mahan, who I know is in the audience, will be delivering a presentation on her work on the WACE-4. So that's very exciting. Now, I want to just jump into Coviu to illustrate how some of the features that were developed specifically for delivering the standardized assessment through telehealth. So bear with me a second whilst I just jump into Coviu. Now, if you're not familiar with Coviu, it's like a video calling service, but with a whole bunch of additional features. And I'm not going to be showing all of those features now. I'm just going to be focused on, I'm going to be talking about the WAIS4 now, and then I'll demonstrate the new DAS21 add-on in just a moment. But the first thing that's useful with the WAIS4 add-on is that it's available from within the video call. So I'm just going to open up the tools bar here in the top right-hand corner. I'm going to scroll down to select the WAIS4 digital stimulus book. And that will open up the stimulus book in both your screen and the client screen. Now, by opening it up in your client screen, it's going to reduce the likelihood of them getting distracted or popping over to another page. And I'll show you what this looks like on your client screen in just a few moments. Now, when you open up the WAIS4, you'll see at the top here an additional toolbar that will appear, and that will allow you to navigate through the stimulus book, select a specific subtest, clear annotations, hide the page, which I'll discuss in a moment, and resize the stimulus book. So, for example, if I wanted to jump down to the visual puzzles subtest and pop between those pages, you can do that from the top there. Now, I'll just quickly mention a key security feature that we've had to develop to ensure that the test is well adapted to telehealth. And that's if Coviu has built in this specific encryption that allows us to decode if a client takes a screenshot of the stimulus book and posts it online, we have the ability to determine which account that screenshot has come from. So we're able to sort of track down the original perpetrator, and that just ensures that none of the tests are published online, and prevents people from being able to cheat. So I think that sort of security is really important when developing a telehealth-specific standardized test. Now, there's a couple of other unique features to this. So as you can see, my mouse is moving around the screen here. Your client will be able to see the mouse move around. And when you click, you can see a mark is left to indicate that you've clicked. So that's equivalent to, say, pointing on a physical stimulus book. I'll just show you what it looks like for a client to click. Bear with me a moment. Oh. So as you can see here, that little CC mark is my client, indicating where they are pointing. So if I was to then click on if the client was then to click on an answer, an annotation, which is numbered, will appear. And that annotation just makes it easy for you to do the scoring offline. And so once the client clicks multiple times, then the annotation will have a new number, which helps indicate that, makes it easier to do that scoring. Now, those annotations will remain if I were to, wait a second, I was to then go back to another page and return to that original page, then those annotations will appear, will remain on that page. You can then clear annotations by clicking this clear annotations button on the top here. And you're also able to hide the page, which just means that the client, the stimulus book is then hidden on your client's screen. You can see that it says not visible to subjects on the bottom left-hand corner of the stimulus book. And this is really helpful if you wanted to flip through the stimulus book past future stimuli without the client being able to see those stimuli and prepare an answer, for example. Now, one of the other key assessments, key features required for the sort of validity and reliability is ensuring that the screen is standardized for each client across each of the tests. So what we're looking at right now is the client's, is me as the clinician, my perspective. I'm going to bring over another screen to highlight what it looks like from the client's perspective. So I've hidden the document, so that's not very helpful. I'll unhide that. So you might be able to notice there's a couple of differences in the way that in the client screen. So first of all, the client is only able to see the clinician, so their own video has been removed. That just helps them remain engaged and focused on the clinician's screen. You'll also notice that all of the toolbars have been removed unless they move their mouse up the top, and this prevents them from accidentally clicking out of the assessment. And they also can't resize or modify the design of the assessment. This just ensures that the test is standardized across patients. So across tests, pardon me. And so that's some of the key features with the new WAIS 4. Of course, that's very similar for the WISC and the Self 5. But I'm now going to very briefly talk about the other assessments that have recently been released in Coviu. So there are 4 new questionnaires that have been released in Coviu that we're very excited about. So that's the DAS 21, the K10, the PSQ9, and the GAD7. I always forget those numbers. And so they're also available up here from the tools bar. So I'll just quickly show you what they look like. So I'm going to scroll down here and I'm going to open up the depression, anxiety, and stress scales, which opens up and looks like this. Now, the great thing about these questionnaires being delivered through Coviu is that they've automatically got scoring, and then you can download those the results, and they're also saved in the browser. So you'll see that instead of having an annotation, a toolbar up the top here, we've got this toolbar down the bottom here. So it gives you the ability to download the results, change who's editing the results, and you've got here a readout of the results in real time. So right now I'm set to editing this, but I'm going to hand over control over to the client. So I'm just going to pretend to complete this like the client on the other screen, and as I go through and answer these, you can see my answers in real time and even see my scrolling as I go through. And you'll notice on the bottom here, the subtotals are added up. So depression is 2, anxiety 1, and whatnot. So I'll very quickly go through and answer all these as if I was a client. I'll just answer up to 12. And then on the client screen, I'll just click complete. And so now I've regained control over the screen. And so I can just click download, which will save the form as a PDF, including the results, and those results will be available in your data collections within Coviu. Now, if you're interested in accessing any of those add-ons, I'll just very quickly show you where you can find them. So here I am in my, popping over into my dashboard, which is where you do a lot of the administrative tasks within Coviu, for those that don't know. And we're going to go over to the add-on marketplace. So the add-on marketplace is where you can download all of those additional fun bits and pieces. And so to access the add-on marketplace, I'm just going to click on the configure tab here, and then jump over to the add-ons and click on find add-ons, which will take us over to the add-on marketplace. So here we are. I've got the PSQ9, the K10, the GAD7, DAS 21. If I was to download the WAIS 4, I just click on this, which then takes me to some information about the add-on, and I can click install. You won't come to that page just because I've got many different accounts. And then and it will install it automatically. Now, to administer, before you can actually use the WAIS 4 or WISC 5, you've just got to jump back into the add-ons tab in your configure menu and scroll down to find the WAIS 4 add-on. Here we go. And then you're going to need to put in your Pearson member ID. So to put in your Pearson member ID, just click on the configure button here, pop in that number. If you don't have your Pearson member ID, you can just check any of your emails from Pearson or jump onto the Pearson live chat. You want to confirm that those two consent boxes are ticked, click save, and then the WAIS 4 add-ons are ready to be used in your call. Those other questionnaires that I mentioned, the DAS, WAIS, the DAS, etc., not the Pearson ones, they don't require any configuring. So once you've installed them into your account, you can use them immediately. So that's it. We've got 5 minutes for Q&A. How are we going for time? So I'll just stop this. 3 minutes. We'll see how we go for time. So I'll stop my screen sharing, and Neil and Melissa, if you wanted to jump in with me, we can answer some of these questions to come through. Fantastic. So I just saw an earlier question from Jacqueline. I'm not sure if you addressed this, Melissa, but is the digital version of the coding and simple search for WISC 5 available again?
So it's not at this stage, and I'm not certain where we're at in relation to that particular research. I am hoping that the WAIS 5, which we're expecting out probably around 2023, 24, might have some further insights into us around that sort of, processing speed and how to do things digitally. But at this stage, they're only administered via paper pencil because, of course, that's the way they were normed. So we would have to look at doing a full renorming if we were to change that again to some other format digitally. So at this stage, unfortunately, Jacqueline, paper pencil.
Another question from Denise. Are there tiered costs based on purchase of available tests in terms of minimum price per order? I assume that's referring to the Pearson add-ons within Coviu. So all of those add-ons will cost $20 per user per month, and then you can use an unlimited number of tests. So the pricing is different to how the pricing all works for the paper-based tests, where so it's $20 per user per month. Leanne asks a question, perhaps for Melissa. Is there any change in the provision of response time on the time test, given that people may be slower to respond using the mouse?
Yeah, so I can't remember if I responded just to you, Leanne, or if I put this publicly. I think I did it publicly, but if I didn't, I apologise. So basically, if you're concerned about the speeded response for where they might be able to click themselves, our recommendation, again, if you have a look at those tables I highlighted earlier, is to actually have a secondary device or at least enough width, I guess, on your camera to be able to see the client responding to their camera. So I would have a secondary device or a second camera set up where I could see basically like over my shoulder here to my screen if I was the examiner. So let's say if Neil was testing me, he would be able to see face to face as we are, but also this secondary device to see me touching, just pointing on the screen rather than using the mouse. And Pete, I think we've discussed this previously, that is an option to have two device cameras showing through Coviu. Is that correct?
Yeah, there's an add-on that'll allow you to bring in a second camera. It's in the marketplace as well. It's called Add a Document Camera.
Yeah. So that would work, and you'd probably want that anyway if you're setting up, and I know Susan's jumped on there to tell us about her research as well, so thank you for that, Susan. I'd definitely be very interested to hear about the results of that. But the document camera would really be recommended when you are doing those additional subtests like block design and any of those other manipulative type tasks. So If you're asking even something like a Wyatt, for example, having children write on a page, maths tasks or written tasks, we would want to be able to see what they are actually doing, because, of course, you want to make sure it's them. You want to see the work as they're completing it, getting that behavioural information that you would get when you're face-to-face typically. So that's going to give you a lot of that additional information. So that would be something that I'd be looking at pretty much regardless of the assessment, because you do have those times where you have additional components to view.
Fantastic. So Lisa's got a couple of questions about costs. I realise we're going over time, so this will probably be the last one. So the Coviu starts at $20 per user per month, and then the Pearson add-ons are an additional $20 per user. The GAS21 is free. So if you wanted to install that add-on, you can do that for free. And then the other three new questionnaires, the K10, PSQ9, and GAD7 are, I think, $2.50 a month or something per user. So that's all we've got time for today. Thank you so much for joining us today, Neil and Melissa. That's been a really fantastic presentation, a real in-depth view of all of the research. And thank you so much, all of our audience members, for joining us today. I hope that's been informative. And we'll be sending through recording and the presentation slides in the coming days. So thank you all so much for joining us today. Bye.